I'm Kate Langbrook, host of Australia's #1 interview podcast for women, No Filter. Every single week, I get to sit across from someone, sometimes famous, sometimes completely unknown, and together we get to the part of the story nobody's heard before. And Mamma Mia subscribers get to hear it first. Every episode of No Filter drops 2 full days before regular listening, exclusive for subscribers. Plus, you get access to subscriber-exclusive episodes across the Mamma Mia network. Treat yourself to something worth listening to and get to hear it first. Tap the link in the show notes and become a Mamma Mia subscriber today.
Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Well, welcome everyone. I'm Brigid Maloney.
And I'm obstetrician Dr. Pat Maloney.
And we've got some Q&As to do today, Pat.
Good. I love Q&As.
I know you love Q&As.
I love hearing from people what's on their mind.
Yes, that's right, because that helps to drive the content towards more patient-led, consumer-led content. It's not just what we want to tell you.
We want to give you what you want to hear.
Yeah. Although we do topics that no one has ever requested, but it is what we think you need to hear. So
Yeah, that doesn't mean it's not important.
That doesn't mean it's not important. It just wasn't on your radar. All right, well, let's start, Pat, with our first caller.
Hi, Dr. Pat and Brigid. My name is Natalie, and I'm coming to you from Queensland. Thank you, firstly, for your gorgeous podcast that I was so lucky enough to stumble across only a couple of months ago when I was diving into the world of TTC, all things pregnancy and IVF. To give you context, I'm a 35-year-old female with a long-standing history of endometriosis and adenomyosis, have not been able to fall pregnant in the past 3 years with my husband, and have had a lot of scarring and adhesions due to the surgeries to correct my condition. I've just had my first IVF cycle that resulted into 2 embryos. Yay! And those 2 embryos are now on ice as I approach my first frozen embryo transfer. FET. So because I'm preparing for that, Dr. Pat, one of my questions is relating to that. Dr. Pat, is there anything that I can do to better support the transfer to sticking and staying stuck, such as lifestyle changes or increasing certain foods and whatnot? I really love your opinion because I'd like to do as much as I can. And if there's nothing that I can do because I'm doing enough already, I guess I can say that I could comfortably relax and just take it easy and know that everything will be okay. My second question is for when I am pregnant and finally about to deliver, is there still a chance that I could have my baby through a natural delivery, or am I looking down the barrel of a cesarean because of all the adhesions and scarring I have? Thank you.
All right.
Great question.
3 years, it's such a long time.
I know. But
2 embryos.
Yeah,
Yay.
That's terrific. So the first part of the question was about about embryo transfers and how to get them to stick. This is I'm gonna up front a little bit outside my area of expertise. I know a little bit about this. The place to get the information is through the IVF provider, because the docs there know all about this and are on top of all of the various research and trials that have been done to see what helps. One of the things that's been a bit newsworthy in recent years in IVF scene in Australia has been the idea of IVF add-ons. You know, if we do this, you might have a slightly better embryo rate of an embryo transfer turning into a live pregnancy. If we wash out the uterus with some stuff, if we give steroids, if we don't give steroids, if we put some oil into the uterus, if we don't do that, and a lot of them have turned out to be quite disappointing. They worked okay in theory, but not really in reality. Sometimes they were thought to work in reality, but when bigger numbers were tested, the effect disappeared. So it actually was not true, even though they thought it was. And some things genuinely help. So IVF provider is where the question should go. and would say, right, when we get around to, because they're both frozen, right, these embryos at the moment, so for some reason didn't proceed with a fresh transfer of either of them. So they're both frozen, and at some point we're going to say, rightio, let's get you ready to have one of those transferred. And the right question to ask the team there is, tell me about anything you've got going on that you think might increase the rate that it would take, and what's the evidence that it truly does? Because the add-ons typically cost a little more. And an ethical provider would say, well, you should only do this if I've got really strong evidence that it helps. Yeah. The other things that as a non-IVF expert that I know helps is being in good condition in the first place. So the things that people can do from a lifestyle point of view, it sounds like common sense, but it's not that common. Is be a non-smoker, absolutely essential. Have a balanced diet. Work on body weight. Prepare for the pregnancy in other ways. Mental health, exercise, having a think about it. If you feel yourself going down a rabbit hole, is this going to take? Is it not? Let's assume for a moment that the team are going to do their best for you and give you the very best chance. So swing that thought around to, what sort of a parent am I going to be?
Yeah.
Which of my personal values do I want to impart to my children? How am I going to run my life as a parent? And trust that at a technical level, beyond those broader things about being in good nick when you go in on the day, at a technical level, the IVF guys are going to be experts at that and recommend the things that have been proven to improve the odds. Yeah. And let's say, for example, you want more than 2 babies, or you want 2 babies but you don't get one out of each of those frozen embryos. Then one thing that people often don't know is that the IVF team can, if you like, go to school a little bit on the recipe they gave you to get those 2 embryos in the first place. And then they might say, well, hang on a minute, this caller is 35. She's well. We expected a few more than 2. So they'll tweak. If you have to go for another cycle, they'll tweak. You just have the same recipe again. That's how we're going to get a little bit more of this and a little bit less of that, and so forth, to try and increase the yield.
Yeah. I'm excited for you. The thing that I don't know whether we've mentioned yet, but our clinic is becoming a provider for Monash IVF.
Yeah, we're very excited about that.
Very excited by that. And those that are long-time listeners would have heard Dr. Erin Stewart come on as a registrar. So she's learning to be a Monash IVF fellow, and she will come on the podcast again to talk about everything IVF.
Yeah.
But so it's led me to speak to the marketing team of Monash IVF, and we were talking about the phenomenon of, because Erin wants socks for everybody that does IVF at Ballarat IVF.
Okay.
Because people say that when they're doing the egg transfer or something, they've got to wear socks. You wear your lucky socks.
Well, I didn't mention that. Wear your lucky socks.
Yeah, and the Monash marketing person said yes, and apparently there's another phenomenon that is that people have a thing of McDonald's fries.
Didn't mention that. See, it shows what I know about IVF. I don't know, socks and fries. Add those to the list.
Yep. So the caller had another question, Patty, and that is separate to the IVF pregnancy, potentially.
Oh, yes.
About whether she should expect a vaginal birth or a cesarean because of the scarring from the surgeries.
Yeah, so the answer is that you're very likely to have the same odds of having a vaginal birth as anybody else. The scarring from endometriosis is outside the uterus. And yes, it causes problems getting pregnant. But once you're pregnant, the action moves to inside the uterus, and the inside the uterus is likely to be normal. Again, adenomyosis affects the uterine wall, but again, the cavity is likely to be normal. So once you're pregnant and up and going, there is no particular problem with either of those conditions raising your cesarean section rate. And the reason why some people are more likely to have cesarean section in an IVF pregnancy is complex. It's related probably chiefly to maternal age, but not really to those conditions. So you should be expecting that when you're pregnant, you would start off with the presumption that you would have a vaginal birth, and move to a cesarean section only in two scenarios: one, where it's got a proven medical benefit to you, or two, if it's your strong personal preference.
Exciting. There you go. And I like it. Pat has already said that you move to thinking about what sort of parent am I going to be, what sort of values do I want to bring into my pregnancy and my parenting. And you've already done that by thinking about, well, when I'm pregnant, how am I going to have this baby? How will I deliver the baby? So you're already there. Very excited for you.
Good luck.
Good luck with those embryos. All right, let's move to – actually, that caller's going to come back at the end. She's got a hot tip for everybody. Okay. So we'll play it then.
Hi, Dr. Pat and Brigid. I have a 15-month-old and I'm starting to think about my next pregnancy. My question is about dilation during labor. I always thought that you dilate from 0 to 10 centimeters and then you push, but that wasn't really my experience. First of all, a week before I gave birth, the doctor checked me and said that I was 4 centimeters dilated and my cervix was soft. She said that I presented as if I wasn't a first-time mom. When I got to the hospital after my water broke, the doctor who checked me was surprised to see that I was 5 centimeters because I wasn't in more pain. Fast forward towards the end of my labor, the doctor on shift checked my cervix and said that while I wasn't at 10 centimeters, that I could stretch to a 10. I gave birth to my son after 45 minutes. Are my experiences unusual? I've never heard of other people dilating in advance of labor or not being fully dilated at the time of delivery. In light of the fact that my cervix looked like a second-time mom's the first time around, should I be worried that on my next pregnancy I could go into labor prematurely? What does it mean if a woman can stretch to a 10? Thank you.
Excellent
question. And you know what? Listening to this for the second time for me, it just goes to show how every little thing that is said to a woman at a vulnerable time.
Yeah. You remember.
Yeah. You hold on to it. And the importance of the practitioner to remember that is so vital because, you might just say an offhanded thing like, oh, you're already 4 centimetres dilated, or whatever. Yeah. That's not quite offhanded. But, there's offhanded things that are said that people just remember their whole life.
I bumped into a patient I passed a woman in the car park of the Royal Women's Hospital once, and she greeted me like an old friend, and I'd looked after her in labour 5 years earlier.
Wow!
And she,
as a student or registrar,
when I was registrar, and I had and she remembered me, and I didn't remember her in particular, but I, said, I hope it all went well and everything. And she said yes. And she said she had a encyclopedic knowledge of what had happened on the day. It was she remembered everything. And she remembered me. She said I was kind. I said, well, that's nice.
You are kind.
But that was, So because to me, she was one of several thousand women I'd looked after in that 5 years, but to her, it was her day.
Yep. Yep. And I'm going to say again, this is the thing about birth trauma. 1 in 3 people say that they have birth trauma. It can be just one of those off-the-cuff remarks that they're holding on to.
Yeah. Yeah.
But anyway, back to our call.
So the when we talk about the cervix dilating from sort of 0 to 10 and then push baby out, firstly, they're averages. And secondly, it's not entirely linear. So most people having their first baby, when the labour starts, there's 0, like the cervix is closed. And then it takes several hours for the cervix to get up to about 3 to 4 centimetres, and from 4 centimetres the labour will become intensely strong and the cervical dilatation will accelerate. And it's unusual to be able to push a baby past out vaginally unless the cervix gets to 10, because for most first-timers the cervix is pretty firm and the opening's just not open until you get to 10. What the caller is describing is entirely normal and, in fact, universal for someone who's had a baby before. So the only unusual thing in this circumstance is that's what
It's her first.
what it was like for her first. But everybody who's had a baby before comes into labour with the cervix a little bit open. Okay, and someone might say it's closed, but really, if you examine a woman. Do a vaginal examination on someone in early labour when they've, for whatever reason is necessary, and she's had a baby before, that cervix will be soft and a little bit open. And that doesn't mean she's, like if you do that at 39 weeks and the woman's come to see you in the room, she's not in labour, it could be 2 or 3 centimetres dilated. That would be extremely common and normal, and doesn't mean she's in labour. That's just where it's sitting. And then with second baby, the reason why it's quicker is that the dilating happens faster, especially when you reach that tipping point of about 4 centimetres. If somebody's having their first baby, it'll still take several hours to go from 4 to fully, but it might only take minutes to go from 4 to fully if someone's had a baby before. So the expected rate of dilatation in labour depends entirely on whether it's your first go or not. And there's a much wider range of expected if you've had a baby before. So this, despite the fact that this being like someone having a third baby in their progress and it happened the first time, it's still unlikely to represent anything out of the ordinary. I think it's a great run that she had. And the cervix must have been really soft, because if they thought it was 9 centimetres but she was able to push the head past, then the cervix that remained must have been nice and soft, or the baby a bit small. And
her next question was, should she be concerned that she'd go into labour prematurely next time?
No, this is not. This is, you'd think maybe there's a, you could see how the answer might be yes, but this is not a pattern that we would consider to be suspect for future prematurity. The patterns that we worry about are if you've had a premature baby, forget what the cervix does in labour. If the baby's come too early before, you're at risk of baby coming too early again. And then there's a highly abnormal pattern where the cervix comes open in the second trimester, painlessly, and a baby at 17, 18 weeks slips out. And that's called cervical insufficiency, which is different. That's a disease that needs treatment. It's not part of the normal range of the behaviour of the cervix. So even though our caller's cervix behaviour in the first labour was unusual, it's not abnormal, and I wouldn't have thought it correlates with any higher risk of problems in the future. What she might have in the future is another cracking labour In fact, the only thing I would probably say is, if you want to have your second baby in a hospital, go in at the first time of something, going in at the first sign of something going on.
Yeah. Don't wait at home and
don't
labour.
muck around, because you might go even faster.
Yeah. I want to ask about subjectivity when people are saying how dilated your cervix is. So how do you know that someone's 4 centimetres is another practitioner's 4 centimetres?
Well, it's a good question. There is no variation in what 4 centimetres means, like that. So there's only errors. Everyone's 4 centimetres is supposed to be the same.
Oh no, I used to umpire netball, and everyone's 3 feet was very different.
Well, that doesn't change. Yeah, somewhere there's a definition of 4 centimetres, we like to train our junior doctors and midwives to make accurate cervical assessments. Not because everyone needs a bunch of internal examinations in their labour, they certainly don't. But there are scenarios in which they do, and some people do, and the least they can be is accurate.
So, yeah, okay.
So there are various training aids that we use to drill for it. So there's I remember one of the hospitals I worked at once, they had a big suitcase, and you open the suitcase up and there are about 20 different sort of cubes, and each cube had a vulva on the front and could be examined internally, and then inside there was a cervix at a certain dilatation. Yeah, right. And we just use that to train, and it's a skill you get quickly,
Yeah.
And then you won't get wrong from that point onwards.
Yeah.
But until you're confident, maybe been working on the labour ward for a few weeks, then people's first examinations should be double checked, and that's something that needs patient consent. So that if you're not ready for that to go into the record as the official answer, then you need a patient, usually someone who's not having their first baby, and you need a patient who's prepared to be involved in the teaching process. And then we sit down with that woman and say we've got a junior person on today. Would you mind if they examined you? And then the examination was repeated by a senior person straight away afterwards to make sure that their answer is correct. And the perfect patient to do that would be a woman not having her first baby who had an epidural.
Yeah. Because actually the VE can be a little bit painful if you don't have an epidural.
Yep, well, of course. So 100% needs patient agreement, and when people are asked respectfully and privately, i.e., you don't ask them in front of the trainee,
because
then
otherwise
they feel bad about saying no. Most people are happy to be involved in teaching, and a lot of people actually are honoured to be involved in teaching.
All right, we've got time for one more, Patty. Here it is. It's also about cervixes.
Hi, Dr. Pat and Brigid. Firstly, thank you for your podcast. This is my second pregnancy that I've been listening to you guys and just find it incredibly helpful and calming. I have two questions. The first one, during my first pregnancy, I developed gestational hypertension during my third trimester. I don't have any obvious high-risk factors other than my age. So I was 35 during my first pregnancy, and I'm 37 now during my second, but not overweight, don't smoke, remained active during my first pregnancy. It did ultimately mean that I ended up being induced. And my question is whether there's anything I could be doing now for my second pregnancy to reduce the risk that it reoccurs this second time around. My second question is, during my first labour, I received 3 or 4 separate compliments about my cervix, which was possibly one of the strangest compliments I've ever received. So just to bolster my ego more, what is it that makes a good cervix? Thanks so much.
How hilarious is that?
That's brilliant.
Anyway, I put it in because of the gestational hypertension, but why on earth would someone get a compliment on their cervix?
I don't know. It's a risky compliment
it is very,
to make. Yeah. I'll answer the first bit.
Yes, probably.
The second bit first.
Okay, good.
Doctors we're weird. We don't think of things. We don't think the same way that we've been trained to think in a certain way, and sometimes we're impressed by normality when we see it. Yeah. And in fact, sometimes to us, the human body working normally is a
thing of beauty,
a joy to behold, right?
Yeah.
It's, there's that, and you say, look at that, will you? Like we're doing an operation, we put the telescope in, and we're expecting bad endometriosis or something. But one thing we'll see is a crackingly normal ovary, and we'll go, look at that. That's and
perfect ovary.
Take a photo.
Yeah,
and literally take a photo.
Take a photo for the patient file.
Yeah. So that there, and sometimes, perhaps unwisely, but sometimes we'll say out loud that there's a sort of certain magnificence in normality, and I'm sure that's all they meant. Yeah. And to see,
and maybe that it was the cervix was doing the right thing at the right time,
all the right things at the right time, not opening insufficiently in labour and needing a Caesar, but just doing its thing perfectly, textbook. Now, Gestational hypertension. This might be a little disappointing to hear, but I don't think there's tons that the caller can do to reduce her risk, because she mentioned age as a risk, and everyone by definition is older when they have their second baby than their first. So she can't do anything about that. She's coming back 2 years later and not 5 years later, which is a good start. She mentioned already being a non-smoker and having a normal body weight. That doesn't leave a whole lot of things left for us to actually intervene on, which is a good thing, right? But I would be getting the blood pressure checked on a couple of separate occasions before the pregnancy starts to make sure that it is really, really perfect coming into the new pregnancy. Exercise, even at a normal body weight, helps manage hypertension, having good mental health, and then plenty of checking in the early stage of the pregnancy.
Would you be on aspirin?
Potentially. Sometimes the evidence for aspirin is stronger if someone's had previous preeclampsia than if they've just had hypertension. The other thing that I would consider doing if the previous pregnancy hypertension had been significant would be to increase the surveillance of the blood pressure around about the time that it kicked in last time. So for some people, 4 weeks between the early antenatal visits before 28 weeks, it's a long time between getting things checked. And if someone had had significant hypertension that kicked in at 22 weeks, then I might start doing more frequent checks than 4 weekly around about that early phase, so that we could start the treatment early.
So, Pat, just really quickly, because we've actually got an episode on this, but if somebody's listening to this and thinking that they've had their first high reading for their blood pressure, what could they expect in terms of treatment?
Well, it's a whole podcast on its own.
Yep, which we've got. So go back and
good. So we take a bunch of extra blood pressure readings to make sure we're not just jumping at one or two high ones, that we've got a consistent and sustained problem. We do some tests to make sure we're not dealing with preeclampsia and that the kidneys are working properly. And then we would, in the presence of ongoing sustained high blood pressure, start some pregnancy-safe anti-blood pressure medications.
Great. All right. Well, I hope that has helped. I think that's all we've got time for, except we've got time for a hot tip. So just stick around and listen to that. But we're going to sign off now and then put the hot tip on and finish the episode with the hot tip. It's a bit of a change up for us. So if all of that sounds appealing, the links are in our show notes, or you can go to our website, which is growmybaby.com.au. All right. Here we go. Until next week, stay well, keep growing those babies. And we're going to leave you with this hot tip.
Hello, my name is Natalie, and although I am not pregnant, this is a little hot tip for anyone trying to conceive and trying to conceive via IVF. Now, I probably had that little inkling thought of maybe this podcast is a little too premature for me because I'm going through IVF and therefore it's a bit more unknown versus someone who's just trying to conceive naturally. But the more that I listen to this podcast, the more I see myself as the same as everybody else. Someone who's trying to conceive naturally may or may not know they have issues that need assistance with, and vice versa. If you're in the IVF world, you don't know how long it's going to take you, and it could take you actually not that long at all to fall pregnant with the support that you need. So please explore the avenues that are out there, the resources that are out there to help you feel more confident with the next journey ahead, because it won't always be this part of your life just trying to conceive. You will get to the next stage. You will get to pregnancy. You will get to delivery. And everything that Dr. Pat, Brigid, and the guest speakers speak about will be just the right tools and knowledge that you're going to need when that time comes. So take care of your mental health, be kind to yourself, and know that you definitely belong here where the kick is and the community of the kick, because I certainly think that for myself. So good luck, everyone. And that's my advice. Just love yourself and know you're doing well.
Hey,
Even though Dr. Pat is, well, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.